Good morning. We open the abstract session number 3. Welcome all. My name is Johanna Laukkarinen. I'm a professor of surgery from Tampere, Finland. And it is my great pleasure to have here as my co-chair, Dr. Shyam Varadarajulu from Orlando. We will have 6 very interesting abstracts here, and 7 minutes has been allocated for each of them for the speaker and 3 minutes for discussion. And we begin with Dr. Kathleen Del Giorno from Vanderbilt University, please.
Thank you. Thank you. Hi, I'm Kathy Del Giorno. I'm an assistant professor at Vanderbilt University, and I'm going to share some of our work on enteroendocrine cell formation in pancreas diseases with you today. And so my lab studies pancreatitis and pancreatic cancer with a specific focus on early events and disease progression. Most pancreatic cancers have a mutation in the KRAS gene. Chronic pancreatitis is a major risk factor for pancreatic cancer, but both conditions are characterized by acinar to ductal metaplasia as an early event in both diseases. And so what this looks like is acinar cells, which have a very specific structure and function, turn off this program in response to oncogenic mutation or chronic injury and undergo metaplasia to form ductal cells. And if the injury resolves, these ducts can resolve and the pancreas can be constituted by normal acinar cells. But in the context of a mutation like KRAS, these lesions cannot heal and instead progress to pre-tumor lesions such as PANN and IPMN, and eventually cancer. And so what we've previously shown is that these metaplastic lesions are not homogeneous, but are in fact constituted by differentiated cell types such as tough cells. And this is something that a student in my lab, Amanda, talked about yesterday. So we recently published a paper in gastroenterology where we asked the question of what cell types and states form in response to metaplasia in the pancreas. And we answered this question by conducting lineage tracing, where we labeled pancreatic acinar cells with yellow fluorescent protein. We induced metaplasia with cerulean, and then we conducted single-cell RNA sequencing. And what we found is that acinar cells move through a mucinous ductal state before forming either tough cells or enteroendocrine cells as distinct lineages. And so this paper contains a number of trajectory analyses that are consistent with this interpretation. And so we don't rely on transcriptomic profiles to identify cell types, but instead we try to include a lot of electron microscopy to confirm that the structure of these cells is actually present. So you can see in D, we have acinar cells by zymogen granules and endoplasmic reticulum. E is a tough cell, F is a mucinous cell, and G and H are 2 types of enteroendocrine cell. And so Amanda talked about tough cells yesterday, and so I'm going to focus on the enteroendocrine population. So when we took a look at this population, we were surprised to find quite a lot of heterogeneity within the enteroendocrine cell subset, including cell types consistent with epsilon, enterochromaffin, gamma, and delta cells by hormone expression. And so somatostatin has been shown to be anti-inflammatory and anti-tumorigenic. Serotonin has been shown to have the opposite effect, and the other hormones have not been shown to play a role in pancreatic tumorigenesis. And so we confirm that these cell types form. You can see expression of these hormones incorporated into metaplastic ducts in the immunohistochemistry, as well as electron microscopy showing granule morphology consistent with these hormones. And we also confirm that these cell types are incorporated into metaplastic ducts associated with human chronic pancreatitis. And so it's been shown before that acinar cells can form enteroendocrine cells by expression of pan-EEC markers like synaptophysin and chromogranin A. And so we asked the question of when these cell types form, what is their pattern throughout tumorigenesis, and do we see the enteroendocrine cell subtypes that we identified in our single cell study? And to answer this question, we conducted immunostaining on tissue from either KC mice or KPC mice, which have half of which had tumors, half of which didn't. And then we identified lesions, had them graded by a pathologist, and then had students quantify the number of positive cells per the number of nuclei in the lesion. And so this ended up being about 1,300 lesions in just this figure. And we found that enteroendocrine cells are most abundant in metaplasia and decrease in abundance throughout pancreatic tumorigenesis. And we found the same pattern for each individual hormone as well. We also conducted co-immunofluorescence to determine if these are distinct populations or if they express multiple hormones. We found that enterochromaffin and epsilon cells are distinct, whereas we saw a lot of overlap between somatostatin and pancreatic polypeptide, which might signify a dedifferentiated population or a bihormonal population, which was recently identified in islets. We also looked at the abundance of these cells in pancreatic tumorigenesis. We looked at 11 patient samples or 20 slides so that we could identify cells in the normal pancreas and then throughout different stages of Pannin and cancer. And consistent with what we found in our mouse models, we found all of these hormones to be most abundant in early lesions in metaplasia. But we were surprised to see quite a lot of pancreatic polypeptide associated with pancreatic cancer. But a function for this hormone has not been identified in injury or tumorigenesis. And more recently, we've been looking at IPMN, and this study was led by Vincent Trin, who has a poster today that everyone should go and look at. And so what he did is he looked at about 71 IPMN, and he conducted immunostaining for the markers we identified in our single cell study. He found that of these 71, 12 had a high abundance of chromogranin A or endocrine markers. Of those, we found that about half expressed serotonin, and the other half didn't express any of the hormones that we looked at. And we also looked at insulin and glucagon. And this staining was done by Amelia Cephas in my lab. And so for those IPMN, we're now going to move to more spatial transcriptomics approaches to identify what hormones are expressed in these IPMN. The hormone expression did not correlate to progression, so this may represent a separate subtype of IPMN. And so in summary, what I've told you is that Asner cells in response to oncogenic mutation or chronic injury undergo metaplasia. And this metaplasia is heterogeneous in terms of the cell types that form. About 15% of these cells are tough cells and about 10% are enteroendocrine cells. This population is heterogeneous and is constituted by different cell types expressing a variety of hormones. And so what we're doing now in my laboratory is we conducted Regulon analysis on our single cell data set. And this predicts that transcription factor NUROG3 is the master regulator for this lineage. We've also identified other candidate transcription factors that might be required for the formation of these different subtypes. And some of these transcription factors have yet to be studied in other systems. We also have a number of mouse models looking at hormone expression in pancreatic tumorigenesis, and we have a postdoc position available to lead this project. And so with that, I'd like to thank my laboratory. Hopefully you had a chance to see Nidhi's poster yesterday on lipid nanoparticles. Amelia in my lab has a poster today looking at the transition between metaplasia and neoplasia. And please stop by Vincent Trin's poster as well to look at all these different IPMN subtypes. Thank you.
Thank you very much for an excellent presentation. The paper is open for discussion.
Hi, very interesting work. I just wonder if you have to study the relationship with the enteric system. Enteric system also release a number of peptides and, and like the polypeptide peptides. So maybe something that may contribute to this transition of the cells during the process of pancreatic cancer progression. I don't know if you ever think about that, the correlation with the enteric system. Is a change in the enteric system and is related to that change that you observe during the progression of pancreatic cancer. Thank you.
I'm sorry, a relationship with what system?
The enteric system.
Oh, the enteric system. So we haven't done that yet, but no, that's a very good point. And what we're thinking of doing is trying to look at expression of nerve markers in 3D to see if these cells are actually making contact with nerves. There's been a lot of interesting papers lately showing that the hormone expression from islets can control Asner cell health and tumorigenesis. So there's either a relationship with the enteric system or a diffusion gradient maybe from islets.
Yeah, I had a question along the same lines, Kathy. I mean, how are you going to get at potential function of these different hormones like the pancreatic polypeptide and things?
So we have a few strategies, but we're using inducible Cres. We can't knock out most of these things in development or else islets don't form and the mice don't survive. So we can target these floxed alleles to pancreatic Asner cells with inducible Cres. And we've also identified a number of Cre mice that should recombine in the metaplasia. So we can just repurpose ductal Cres for this. And there are floxed alleles for serotonin. We made one for somatostatin, and there's a pancreatic polypeptide system that's been developed in Europe that we can import.
Thank you again. We move on.
Thank you for the introduction, and thank you for inviting me for this session, and great opportunity to share my study, which is serum immune profiling using PROCEED cohorts. So before I present my data, I'd like to acknowledge that many people contributed to this work, especially thanks to my wonderful mentors, Drs. Park, Hussein, and Haptijian, and also lab members, and the Stanford HIMC, and most importantly, CPDPC patients and donors and PIs and co-authors. Of course, funding is from NIH, NIDDK. So as you all know, this pancreatitis can progress from acute to recurrent acute and chronic pancreatitis. And currently, there are no specific early diagnostic or prognostic biomarkers predicting recurrent acute pancreatitis or chronic pancreatitis. And inflammation is one of hallmark for the pancreatitis, and serum immune marker detection is beneficial to identify non-invasive biomarkers. And then it can be used for potential therapeutic target for the pancreatitis. So for this study, we are aiming to determine the immune markers that differentiate non-pancreatitis from acute and chronic pancreatitis. And secondly, to determine whether certain cytokine pathways are associated with the progression from the non-pancreatitis to acute pancreatitis to chronic pancreatitis. And third, to determine whether there are distinct circulating cytokine associated with the pancreatitis risk factors, including alcohol, smoking, and diabetes. So we use PROCEED cohorts, total of 231, 56 control without pancreatic disease, and 24 disease control with chronic abdominal pain, 38 acute pancreatitis, 56 recurrent acute pancreatitis, and 57 chronic pancreatitis patients. As you can see, the ratio of gender and average age is pretty similar to all the groups. So for the serum immune profiling, we use this DNA oligonucleotide conjugated this Olink assay. So this is brief overview how it works. So basically, Olink use this DNA oligonucleotides conjugated antibodies upon target binding. They are brought into proximity, and they are hybridized and extended by DNA polymerase, essentially turning into this qPCR output. So first, this is our analysis plan. And first, we were comparing these all pancreatitis groups versus controls. So we found significantly elevated these 33 immune markers. And then using pathway analysis, we had identified this TNA alpha associated pathway signaling pathways. And secondly, we were analyzing AP-RAP-CP to controls. And for this, we also use IPA analysis. So using the comparison analysis, we were able to identify activated or deactivated molecular pathways in over the disease progression, AP-RAP-CP. As highlighted here, this macrophage classical activation pathways are gradually activated over the disease continuum. And then this pathway associated molecules are listed here, including TNF-alpha, IL-17, IL-18. Next, we are comparing among the different disease states. So as you can see here, these 5 immune markers were significantly differentially altered in CP versus AP and RAP, especially the CCL20 and IL-17 were gradually upregulated over from AP, RAP, CP. And then MCP2 was significantly downregulated in CP versus AP, and IL-17 again is significantly upregulated in CP versus RAP. And again, this CCL20 and IL-17 was significantly upregulated in this CP over this chronic abdominal pain group. Actually, these two molecules are connected through this Th17. Once this CCL20 is secreted from the various immune cells or epithelial cells or endothelial cells, they recruit the CCL6 positive cells, and CCL6 is mostly expressed in Th17 cells, which secrete this IL-17. And this Th17 and also IL-17 signaling pathway also supported by our previous papers, including CCL6, CCL20, axis found in the hereditary pancreatitis, and Th17 used fibrogenesis in the chronic pancreatitis mouse models. And we next constructed this ROC curve, and 2 immune markers, IL-17 and ST1A1, could predict this CP over the chronic abdominal pain group. So lastly, we were also analyzing and then trying to identify significantly altered immune markers that in AP, RAP, CP with the different status of pancreatitis risk factors, alcohol, smoking, and diabetes. So as you can see in this table, we were able to identify their upregulated or downregulated immune markers in different disease state and or combined groups by the different status of risk factors, smoking, alcohol, and diabetes. So in conclusion, pathway analysis revealed increased activation of pro-inflammatory pathways over the disease progression, AP, RAP to CP, and IL-17 signaling could differentiate CP over all other groups, suggesting the involvement of Th17 cells in the CP. And IL-17 ST1A1 could used as a predictive biomarkers for CP over chronic abdominal pain group. And then several immune markers also found to be associated with the pancreatitis risk factors. Thank you for your attention.
Papers now open for questions. I'm a clinician. I don't know much basic science, but do you think this will be a pathway that can be targeted with medications and things to prevent our disease progression?
Yeah, so actually IL-17 is actually it can be targetable, and also but the thing is IL-17 itself is also very important homeostasis in the gut, the intestine. So we have to be careful though. But I think it's doable.
Hi, Bomi. Thank you very much. Great presentation. Just wondered whether there was a different immune signature for hereditary chronic pancreatitis versus the risk factors that you mentioned.
Can you repeat? Sorry.
Just wanted to ask whether there was a different immune signature for the hereditary chronic.
Yeah, actually, we trying to identify different etiologies of the chronic pancreatitis, but there are only a few hereditary cases in this cohort.
One question. So about IL-17, there is always argument about IL-17 function in pathogen-associated function and also inflammation-associated function. When you do the analysis in different groups, have you identified certain cytokine clusters which is more dominantly in pathogen-associated, or like, for example, like infection, or it's more like inflammation-associated function?
You mean the pathway analysis that we identified? Is it more like pathogen associated or inflammation? We didn't really find, but there was a cytokine storm related pathway we found, and also inflammation related, not really with the pathogen related pathway we found.
Oh, okay, okay, yeah.
Thank you.
Thank you again. And then we move on and invite Ilya Kukovsky from LA to speak about disordering of acinar cell cholesterol trafficking in pancreatitis, roles of NPC1. Ilya, please.
So this story started, the study where we examined the consequences of knocking out the GNPTB gene coding for a key protein in the mannose 6-phosphate mediated pathway of hydrolyzed delivery to the lysosome. And unexpectedly, quite unexpectedly, we found that this caused a profound dysregulation of cholesterol in acinar cells in the pancreas, not in the blood. Cells uptake their cholesterol from the circulation through endocytic pathway in the form of mostly esterified cholesterol in LDL lipoproteins, and it ends in the lysosome, the major controlling hub for cholesterol distribution and trafficking. The upper top, the top right corner of this cartoon shows the three proteins critical for cholesterol transfer: lysosomal associated membrane protein LAMP2, the soluble protein NPC2, which mostly store and present the de-esterified cholesterol to the main character in our story, the multi-spanning protein NPC1. And until recently, it was not clear how cholesterol is transferred through this thick glycocalyx to the lysosomal membrane. And then they discovered this hydrophobic cavity tunnels in the molecule. So what we found is that there was upregulation of, there was an increase in cholesterol content in the pancreas across different models, non-alcoholic, alcoholic, ex vivo model, including in human acinar cells. And on the bottom, the lipidomic mass spectrometry analysis showed quite significant increases, several fold in different cholesterol esters. And there was no change in, for example, phosphatidylethanolamine or phosphatidylserine, and importantly, no change in liver cholesterol in this knockout. Maybe even more important, we found changes in cholesterol subcellular distribution. Uniqueness of cholesterol is that it allows the membrane to retain their integrity without becoming rigid. And therefore, the plasma membrane has like about 40 molar % of its lipid of cholesterol. So in the wild type acinar cells, the specific probe for pre-cholesterol Philippine lights up the plasma membrane and also areas rich in the zymogen granules. And cadherin is a specific probe for plasma membrane. And you see that in the wild type, in normal pancreas, there is almost complete colocalization of cadherin with Philippine. And in the knockout, we see a huge change, accumulation of cholesterol in what we showed in the lysosomes and autolysosomes, and the colocalization is lost. So this is quantification of the changes. It's across, again, the model shown more robustly with the colocalization Pearson coefficient. Okay, and then cholesterol is gone from the zymogen granules. There is decrease in its colocalization with amylase, and it's increased in endolysosomes, a huge increase in colocalization with LAMP2, RAMP9. And because the cell has a lack of available cholesterol, it ramps up its synthesis. So mRNA, mRNA for key protein in cholesterol biosynthesis is increased again across the models. And so this paradoxically exacerbates cholesterol overload. So we found that the same thing is in the human disease. This is an increase in HGM CoA reductase, and each panel is from a different patient with pancreatitis or with normal pancreas. So we use several approaches to see what happens when we try to modulate cholesterol. And here, simvastatin relieved the cholesterol overload and decreased necrosis, activation of NF-kappa B, ER stress, less ubiquitination, and the CHOP, which is a marker of ER stress. And importantly, it almost eliminated trypsin activation. I don't have time to show that it also largely normalized mitochondrial dysfunction. Then, because we found accumulation of cholesterol in the lysosome, we looked what's happening with NPC1. And we found a decrease in NPC1 again in across the models. And this is an interesting case of this combination of alcohol feeding and low dose cerulin. Treatment alone don't decrease NPC1, but with pancreatitis it's dramatically decreased. Again, we had several approaches to and this is happening in human pancreatitis, also a huge decrease in NPC1, like 5-fold. So we used several approaches. We generated a pancreas-specific NPC1 knockout, and we saw the similar changes, accumulation of NPC of cholesterol in endolysosomes, increase in its level, and the synthesis in HMG CoA reductase. Cholesterol was increased with NPC1 siRNA knockout and with specific inhibitor U18. So then we saw that NPC1 deficiency elicited pancreatitis responses, increasing necrosis, the NF-kappa B activation, again, trypsin, and decrease in the transcriptional regulators of mitochondria biogenesis, PGC1 alpha, and function. So in the last couple of slides, I want to show you the recent data that we looked how NPC1 is decreased. So of course we started with mRNA and it was not decreased, but in the contrast increased a lot. Then we asked maybe it's degraded by proteolysis, but no, the inhibitors of proteolysis, here it's a broad spectrum inhibitor of cysteine proteases and specific inhibitor of cathepsin B. They did not prevent the loss of NPC1, but it was prevented by proteasomal inhibitor and the inhibitor of endoplasmic reticulum-associated degradation pathway, ERAD, this ER1. So we showed, again, I cannot show this, that NPC1 is stuck in the ER likely because of its misfolding. And because of that, it is degraded through ERAD. Then in other cells, just 2 slides, in other cells, HSP70 maintains NPC1 level. So we applied enhancers of HSP70, actually arimoclomol and another compound GGA, and they, lo and behold, really prevented the loss of MPC1, relieved cholesterol overload, and then they alleviated pancreatitis responses. So for those of you who are long enough in the field, you may remember that in early 2000, there was a lot of interest in hyperthermia and other treatments that enhanced heat shock proteins, and this was championed by most prominently Ashok Saluja. And then the mechanism remained unknown, and the drugs were not developed, so the interest faded. So we probably need to revisit this. So my summarizing simple schematic shows what we found. Our data indicate that MPC1 misfolding causes ERA degradation and then cholesterol overload. This leads to organelle, prominently mitochondrial dysfunction and pancreatitis pathology. Of course, we need to, this raises a lot of questions about exact mechanism, potential molecular targets. We just need to figure out how it will unfold. Thank you very much.
Thank you. I think we'll move to the next presentation because we are running short of time. So
Yes.
Thank you.
Thank you, Ilya.
Thank you.
Oh, okay. Thank you.
So the next speaker will be Robert Farquhar from Freeman Hospital, and he's going to talk on prevalence and temporal trends of sarcopenia and sarcopenic obesity in severe acute pancreatitis, a prospective observational cohort study.
So hi everyone, my name's Rob. I'm a final year medical student from Newcastle University in the northeast of England. And first I'd just like to say a massive thank you to the APA for giving me this opportunity and also funding my travel, which is obviously, as you can imagine, for a student, it's quite hard. Today I'm going to talk to you about the research I did in my MRes year, which I did last year, Masters by Research, where we investigated the prevalence and temporal trends of sarcopenia and sarcopenic obesity and severe acute pancreatitis, which was a prospective observational cohort study. So first, if we look at severe acute pancreatitis, so in the United Kingdom, the incidence of acute pancreatitis has doubled in the past 3 decades and now accounts for 20,000 hospital admissions a year and costs the National Health Service an estimated £200 million. Severe acute pancreatitis is also shown to have a significant impact on long-term quality of life, with the loss of physical function secondary to the long ITU stays and muscle loss. Finally, the prevalence and impact of sarcopenia and severe acute pancreatitis outcomes remains unknown. So this is what we kind of looked into to investigate. So next, what's sarcopenia? So sarcopenia is a generalized skeletal muscle disorder, which is characterized by a loss of functional strength due to a decrease in skeletal muscle mass, strength and quality. And sarcopenic obesity is simply where a patient is sarcopenic and also obese, which we define as a BMI of greater than 30. And again, sarcopenia has been shown to be associated with increased morbidity and mortality in numerous different conditions. However, this link with severe acute pancreatitis has not yet been established. Here you can see a CT scan of an individual with a healthy muscle mass. I've kind of drawn some arrows towards the main abdominal muscles, including the psoas muscle, and you can see the large volume of those muscles. However, when you compare that to an individual with sarcopenia, you can see that muscle volume is greatly reduced, and you can also see kind of dark infiltrates within the muscle, which kind of signifies fatty infiltrates and reduced quality of muscle as well. So the main aims of our study were to investigate the prevalence of sarcopenia and severe acute pancreatitis patients at admission and then at various different time points following this. And then we also investigated the impact of sarcopenia and sarcopenic obesity on severe acute pancreatitis outcomes, focusing specifically on complications and mortality. So how do we go about this? We identified patients from a prospectively maintained ITU database about all ITU admissions to the Freeman Royal Hospital, which is a hospital in the northeast of England and is a tertiary care centre for severe acute pancreatitis with a population of about 4 or 5 million people. We then determined sarcopenia by measuring the area of the abdominal musculature on a CT scan at the level of the third lumbar vertebrae. And this was done by 2 trained investigators. Then retrospective analysis of patient records revealed information about past medical history and complications and interventions undergone during the patient's hospital stay. And you can see the inclusion and exclusion criteria. So any patient over the age of 18 with severe acute pancreatitis, and then excluded were patients with recurrent and chronic pancreatitis. So moving on to the results. So we managed to identify 141 patients with severe acute pancreatitis. You can see here the median age of 59, with a male to female ratio of slightly higher in the males, 1.5 to 1. The most common etiology of the severe acute pancreatitis was gallstones, followed by excess alcohol consumption. And you can see here the rates of organ failure that were in our cohort. So nearly all patients had respiratory failure, and just over half had renal failure. And again, just over half had both types of organ failure that we look for. And finally, the sarcopenia assessment between the two trained investigators was shown to be had a very high correlation when we used Spearman's rank. So this is the results of the prevalence of sarcopenia in severe acute pancreatitis patients. So you can see here on admission, a very high proportion, around 79% of patients were found to be sarcopenic on admission to hospital. And of these 111 patients, around 60% were shown to have obesity as well, so they were sarcopenic obese. This proportion of sarcopenia rose dramatically until at 3 months post-admission, nearly all patients were found to be sarcopenic. Furthermore, at 12 months, over 2/3 of patients were still sarcopenic, which is still a very high proportion of patients. You may notice that there was quite a big drop-off in patients from admission to the 12-month point. This is mainly due to mortality within the group. However, also as patients leave hospital and recover, there's less clinical need for a CT scan, therefore making it impossible to assess, which is one of the main drawbacks of this method of assessing sarcopenia. So I'm just going to quickly run you through what this muscle loss actually looks like in these patients. So you can see here the patient on admission had quite good muscle mass in the psoas muscles and the other abdominal musculature. However, after 3 months, you can see there's a dramatic reduction in the size of the psoas muscles and other muscles. And then you can see at 12 months, this musculature still hasn't recovered, and this patient remains sarcopenic a year after their admission to hospital. This is just a quick slide summarizing some of the findings about the post-pancreatitis complications and interventions these patients underwent. So as you can see, paradoxically, the rates of complication and intervention are actually higher in both the non-sarcopenic and sarcopenic groups. This is because the patients in the sarco-obese group and sometimes the sarc group just didn't simply live long enough to develop a lot of these complications, as we'll now talk about in the mortality slides. So here you can see the mortality, comparing the first graph, comparing the non-sarcopenic group to the sarcopenic group. You can see the mortality in the non-sarcopenic group is 10% compared to the much higher 35% in the sarcopenic group. When we broke down the sarcopenic group into both the sarco-obese group and the sarc non-obese group, again, you can see there was much higher mortality in the sarco-obese group compared to just the regular sarcopenic group. This Kaplan-Meier curve further highlights this. You can see the dramatic difference in mortality in the sarco-obese group compared to the sarc group and the non-sarc group. And finally, to take this one step further, we looked to see if we could identify any predictors of mortality in severe acute pancreatitis. So we took some variables that were significant in univariate analysis, and we included them in a logistic regression model. And we were able to show the age, the number of organ failures, and the presence of sarco-obesity on admission to hospital were all significant predictors of mortality in severe acute pancreatitis. So just to quickly conclude, sarcopenia was highly prevalent in patients admitted to hospital, present in 79% of them. And of these 79%, 60% were also sarcopenic obese. 2/3 of patients remain sarcopenic at 12 months. This shows the importance of good nutrition and physiotherapy care post-discharge to help these patients regain a functional level of muscle mass again. And finally, sarcopenic obesity was shown to be a significant predictor of mortality in severe acute pancreatitis. This suggests that potentially body composition analysis could be used as a predictor of mortality at admission in severe acute pancreatitis. And further studies are warranted to assess sarcopenia in a prospective manner so that both muscle quality and quantity can be assessed with a view to develop rehabilitation programs after discharge. So a massive thank you. I'd like to say thank you to my supervisor, Sanjay, who helped me a lot with this project, and also my colleagues, Scott and Nesta, who helped with the CT scan analysis. Thank you very much for listening. Maybe I have so many questions.
Robert Sutton from Liverpool, United Kingdom also. Thank you for that very thought-provoking presentation. Have you a definition of sarcopenia? Is it some sort of absolute value that you can quantitate? That's the first question. And the second is, have you looked at the patient's nutrition and the patient's records of infection and any other contributing factor that might contribute to the progression of sarcopenia, and what we should be doing about it? Because obviously it delays patient recovery and it's a marker of progression to likely death.
Yeah. So the first question was about the definition of sarcopenia, and there's kind of a number of different ways it's defined. So you can define it radiologically like we did, which has kind of got predefined values that are very absolute. So you measure the area of the psoas muscle and divide it by their height, and that gives you a value. And if they're below that value, they would be sarcopenic. But there's other methods of assessing it, like a hand grip assessment. So there's various assessments you can actually do with the patient kind of in person. So I think probably the best way to do it would be a combination of all the different ways of assessing sarcopenia. Would probably be my answer to that one. The second question, we looked at quite a number of different, we looked at infection, we looked at a lot of different things. I didn't have enough time to put everything in the presentation, but we've looked at a number of different variables that happen to that patient. However, the retrospective kind of analysis was a bit hard at times because the patient records are not brilliant, but I think when with the paper we're writing, there's a lot more information on that in the future.
Thank you. I think we're running late by about 10 minutes. Thanks so much.
Yes, thank you so much. Please, you can address the rest of the questions to Robert during the coffee break. Thank you. And then next we invite Stuart Weisberg to speak about obesity primes the exocrine pancreas for inflammation. Please.
Okay, I'd like to thank the APA Abstract Committee for this opportunity to present my work today. I have one disclosure. So toxic and metabolic stressors such as obesity, diabetes, ethanol consumption, and smoking all contribute to the development of pancreatic exocrine disease. My lab studies pancreas tissue immunity using a human organ donor resource that was initiated in the lab of my mentor, Dr. Donna Farber. The purpose of this study is to define how pancreatic stressors shape pancreas tissue immune cells and immune regulation in the hopes of revealing immune factors that drive pancreas disease risk. Our study cohort comprised 43 organ donors without exocrine disease. Shown here are the cohort characteristics, including several well-known risk factors for exocrine disease, such as BMI ranging from 20 to over 40, type 2 diabetes, smoking, ethanol. In our study, we used multiplex IHC and flow cytometry on pancreas tissue sections and immune cells, as well as functional analysis of primary pancreas immune cells. So in the imaging study, we used a multiplex IHC panel of pancreas, where CK19 was used to label the ductal system, chromogranin labeled the neuroendocrine islets. The pancreas immune lineages were labeled based on previous work by ourselves and others. The exocrine pancreas, there are CD163 positive macrophages throughout exocrine pancreas, and they express varying levels of CD11C. The T cells in the pancreas are predominantly of the CD8 lineage with a smaller population of CD4s. An AI-enabled image processing software first segments the tissue into ductal areas shown in yellow that are CK19 positive, the neuroendocrine islets shown in white, and then the areas in between are defined as acinar. This is followed by cell segmentation and phenotyping based on marker expression. So we performed quantitative analysis of T cell lineage densities in the pancreas tissue compartments. And we found that BMI correlates with CD8 T cell densities in ductal and acinar areas and with CD4 T cell densities in acinar areas. We also used multivariable models, which showed that BMI is the main predictor of exocrine T cell density after adjustment for factors such as HbA1c, smoking, ethanol consumption, age, and sex. We performed flow cytometry to take a more detailed look at these T cells. And flow cytometry shows that across all the BMI levels, the T cells in pancreas have a predominant TRM phenotype. So TRM are defined as effector memory T cells. Usually they're quite functional with a lot of cytotoxic molecules and cytokine production. And they have additional expression of tissue retention molecules, such as CD103, and CD69, which is expressed on the CD8 lineage in pancreas. And the CD4 lineage in pancreas tends to be CD69 single positive TRM. But the TRM are predominant across all the BMI levels, indicating that the cells that are accumulating are TRM. So previous work in my lab showed that pancreas macrophages express key molecules for controlling T cell activation and function, such as MHC class 2, the co-stimulatory molecule CD86, CD58, as well as the checkpoint molecule PDL1. In addition, pancreas macrophages cluster with T cells in exocrine pancreas. Shown here is exocrine pancreas CD8 T cells clustering with CD163 positive macrophages, which also co-express high levels of HLA-DR. Using flow cytometry, we show that the highest expression of T cell activating molecules is on a CD11C high, CD163 high pancreatic macrophage subset. And this is just quantifying these markers on that subset compared to the rest of the macrophages in pancreas. In our imaging study, we showed that the CD11C high, CD163 high macrophage density in the acinar areas correlates with BMI. So you can see here you have a non-obese donor with CD163 positive macrophages throughout the exocrine pancreas. And in the obese donor, more of those macrophages are CD11C positive. In multivariable models, BMI is an independent predictor of these macrophages after adjustment for hemoglobin A1c, smoking, ethanol consumption, age, and sex. Using flow cytometry, CD58 is a key molecule for T cell adhesion and co-stimulation that's expressed by macrophages. And we showed that there's higher CD58 expression on the CD11C high, 163 high pancreatic macrophages. And this correlates with BMI. So higher expression of CD58 in obesity. And this effect may further enhance T cell interaction and co-stimulation in obese individuals. We established a co-culture system to functionally assess macrophage T cell interaction. In the system, primary pancreatic macrophages are plated with T cells, and the T cells are activated through the T cell receptor without exogenous co-stimulation beyond that that's provided by the macrophages. So in the system, pancreas macrophages have the capability of activating blood T cells, inducing a strong proliferative response, strong expression of cytotoxic molecule granzyme B, and in the CD8 lineage, strong expression of the tissue retention molecule CD103. In studies where we looked at the macrophage-derived factors that shape T cell function, we found in this co-culture system that macrophage CD86 is important for T cell cytotoxic differentiation. TGF beta plays an important role in the expression of CD103 by the CD8 T cells, and CD58 potentiates both CD103 and granzyme B expression. We sorted macrophages based on their CD163 and CD11C profile, and we found that the CD11C positive macrophages had greater capability to induce co-expression of tissue residency and cytotoxic molecules on CD8 T cells. And finally, in studies of primary pancreas macrophages in co-culture with pancreatic TRM, we found that macrophages promote TRM cytotoxic degranulation as defined by LAMP1 translocation in the granzyme B positive TRM, and that BMI correlates with enhanced activation-induced cytotoxic degranulation of the TRM. In addition, pancreatic TRM show high production of Th1 cytokines such as interferon gamma and TNF alpha, which is not shown, but this function is not correlated with BMI. So in summary, higher BMI associates with changes in macrophages and T cells of exocrine pancreas. We have higher density with increased BMI of TRM with cytotoxic and cytokine functionality, higher density of C11C high 163 high macrophages. They show higher CD58 expression, greater capability to promote T cell activation, cytotoxic functions. These macrophages interact with T cells in pancreas tissue, and therefore we propose that obesity may sensitize exocrine pancreas to inflammation by macrophage T cell interactions. So I'd just like to acknowledge my mentor, Dr. Donna Farber, Jiayuan Chen, who played an instrumental role in our pancreas cell processing, as well as my students, Shanila Shakil and Michael Chait, who collected most of these data. In addition, I'd like to acknowledge the funding agencies that supported this work, and I'll take any questions.
Thank you very much. Interesting work. One short question and answer, please.
Very, very interesting study. In terms of co-culture of macrophages with T cells, what is it? What is the antigen which will stimulate T cell? Or you think it's a direct stimulation of the T cells by macrophages?
So in our co-culture system, we are activating the T cells through their T cell receptor using a polyclonal stimulus, which is basically an anti-CD3 antibody. So it's not an antigen-specific stimulus. It's through the T cell receptor, but it's a polyclonal stimulus.
But in terms of the pathogenesis of the pancreatic disease, for example, pancreatitis, what is the likely antigen that the macrophages will use to stimulate T cells if T cells are supposed to be playing a role in the pathogenesis?
I think that's a very interesting question. What antigens are these cells presenting? Obviously you think of there's various viral antigens, various autoantigens, but we're actively working on that, trying to define the antigen specificity of these T cells, but we're not there yet. Thank you.
Thank you again. We move on.
So we'll move on to the last presenter. It's going to be Dr. Tamal Tykes from the NIH talking on T1 signal intensity ratio and staging in chronic pancreatitis.
Good morning. My name is Tamal Tykes from Indiana University, and I will be talking about the T1 signal intensity ratio as an imaging biomarker for staging of chronic pancreatitis. We'll try to finish this in 7 minutes. I will split it into 3 sections. First of all is why we need a new imaging biomarker for chronic pancreatitis and why this should be a parenchymal imaging biomarker. And I will talk about the T1 score. So rationale for a new imaging biomarkers has been around for a while, but it has been studied and published several times. First of all, Cambridge criteria does not detect early chronic pancreatitis changes. Second, progression of chronic pancreatitis is more readily seen in the parenchyma than the ducts. Third, there is discordance between the ERCP and MRCP interpretation. The Cambridge classification is published for ERCP, but we are using it for MRCP. And better inter-observer variability is needed for diagnosis and follow-up of chronic pancreatitis patients using imaging. And MRI biomarkers have been better correlation with histopathology than the Cambridge classification, and it's about time. This has been Cambridge classification has been published in 1983, and these are the tools that we were using back then. We are not using them anymore, but we are still using Cambridge classification. So why we should look into the parenchymal imaging? Histopathology of the chronic pancreatitis is defined as a triad. The first one is ductal dilatation and distortion. Second one is parenchymal fibrosis. And the third one is loss of acinar and islet cells. We have a criteria for changes for the ductal dilatation and distortion, but we still do not have a criteria for parenchymal fibrosis and loss of acinar cells or atrophy. Why is this important? Because ducts are about 5% of the parenchyma, whereas the exocrine cells and extracellular matrix constitutes more than 90% of the parenchyma. We are still not looking into the changes within the parenchyma, just using the ductal imaging to diagnose the chronic pancreatitis. A study was published recently looking into 25 patients with chronic pancreatitis, and the question was the ductal imaging or the parenchymal imaging was imaging biomarkers that is useful for follow-up of the chronic pancreatitis patients. And their results show that the parenchymal imaging markers were changing over the course of 4 years, whereas the ductal imaging remained stable. So morphological progression of the patients with chronic pancreatitis is easier seen with the parenchymal than the ductal imaging. So let's talk about what is T1 score of the pancreas. These are two T1 weighted images obtained in almost every MRI imaging study. We are not using any special imaging technique. The patient on the left is with no known pancreas disease. On the right is known pancreatic chronic pancreatitis. And as you can see on the first image, there is quite a bright signal of the T1, which is normally seen in normal pancreatic tissue. And the pancreas shows its T1 signal on the chronic pancreatitis patients. And we measured the signal intensity of the pancreas and the spleen and take a ratio of this, and J is T1 signal intensity ratio, or simply called T1 score. So we published this out of the results of the PROCEED study, which is a longitudinal core study established and developed a framework for conducting biomarker, genetic, and mechanistic studies and for the chronic pancreatitis patients. And it has been funded in 2015 and started enrolling patients in 2017. There are over 1,700 patients right now and are still enrolling patients into this 3 cohorts. Out of the 1,163 MRI images, 820 was available for analysis for the study. And in terms of methods, this is a highly scalable real-life study, included all MR hardware vendors, both T1, 3 Tesla and 1.5 Tesla images were used, and we used a gradient echo T1 image, which are already performed in almost all abdominal MRI examinations. It takes only 20 seconds to perform, and no contrast was necessary. And these results were shown in the mechanistic stages of the chronic pancreatitis, which separated patients into 7 groups. And these criteria included Cambridge classification, clinical features by the PROCEED study, and also calcification seen on CT. And the T1 score was 1.3, average number was 1.3 in the patients with no pancreas disease, which drops to 1.05 in patients with severe chronic pancreatitis disease. And 1.21 was sort of a threshold for very early changes of chronic pancreatitis. And this shows you the graphical representation of the same T1 signal intensity ratio over the course of the disease and the severity of the chronic pancreatitis. So T1 score has been also correlated with exocrine pancreatic insufficiency. The study was published several years ago, and the question was, can the T1 score detect early chronic pancreatitis? There were 42 patients with a suspected chronic pancreatitis, but normal MRCP and EPFD was performed to assess the exocrine pancreatic insufficiency. There was excellent correlation between the bicarbonate level in the pancreatic juice and the T1 signal intensity ratio, and the inter-observer variability was excellent. So in that study, the threshold of 1.2 was 77% sensitive and 76% specific to detect the abnormal or low bicarbonate level in the pancreatic juice. We also correlated this with the histopathology, and we looked at the 60 pancreatic resections for chronic pancreatitis, measured the T1 score and also Cambridge classification, and the results comparing the T1 score with the Cambridge. The T1 score had a better correlation than the Cambridge for fibrosis score given by the Ammons criteria. So in conclusion, T1 score is a highly scalable and practical imaging biomarker for chronic pancreatitis. And if I have to ask questions to myself, can we use T1 score in clinical practice today? Answer is yes. Can we use T1 score in research today? Yes. Do we need to purchase and install any software or hardware? No. If you want to read more about this, you can look into this publication, which is August 2022, very recent. And if you have any more questions, we'll be happy to answer.
No questions. Any questions from the audience?
In mice? No, no mice. We don't image mice in radiology.
Okay.
Okay.
Thank you so much. We thank again all the speakers and the audience and close the session. Thank you.
Thank you.
Yes.